Today we're going to do a basic pulmonary exam with some fairly special techniques in there as well. And so we're going to do, I'm going to assume that you have vital signs, you have a respiratory rate, and if there's, somebody might have taken a pulse oximetry to give you an oxygen saturation. If not, at a minimum, you should get the respiratory rate yourself. I've just washed my hands, and I'm going to introduce myself. Hi, I'm Dr. Nancy McDaniel. How are you today?
I'm doing well. I'm Mike. Nice to meet you.
Nice to meet you, Mike. And the first thing you do in a pulmonary exam, as in any exam, is make sure your patient is comfortable. You feeling all right?
Yes.
And comfortable there? Since we're going to be focusing on the pulmonary exam, is it all right if we take your gown down so we can inspect your chest? And there's always drapes available. So if a patient, we're using the gown as a drape over his lap here, but there's always sheets available to drape a patient. And you want them to be comfortable. So the first thing with a pulmonary exam is we're going to inspect the chest from the anterior aspect, as well as I'm going to walk behind the patient to see if he's breathing comfortably, and is there, just visually, is there symmetric chest movement, which there is. I'm also looking to see if there's any scars, rashes, anything else that, might impact the chest exam. So his chest is very symmetric. He's breathing comfortably. I don't see any defects in the chest. And the other thing, as you're looking at this, you're going to see if he's using any accessory muscles for breathing, if there's any intercostal retractions, or if there's asymmetry, which I don't see. I would then typically, I'm going to look at your breathing behind. It's always good to expect to tell the patient what you're doing. And so again, he's breathing very comfortably, very symmetrically here. So, and that is your basic inspection of the chest for the pulmonary exam. The next thing I'm going to do is assess for chest expansion to see how even that is. And that's something that I have to do from behind. What I'm going to be doing is placing my hands roughly in this position with my thumbs over the spine and asking him to take some deep breaths. And what I'm checking for is to see how much the chest expands and if it's symmetric. So, Mike, I'm going to put my hands on your mid-back and ask you to take a big deep breath in. Excellent. And let it out. And again. And let it out. And so what I'm doing there is assessing for chest expansion, and he has good breadth of chest expansion, and it's very, very even. We're going to do the auscultation of the breath sounds. These are typically done anterior as well as posterior. You can also listen laterally because the lungs are, in this area as well. And so, but I'm going to start anteriorly. Again, the stethoscope, the earpieces point forward, and for the pulmonary exam, you're going to be using the diaphragm. And mostly you want the patient to be breathing comfortably but taking deep breaths, and you'll develop a technique kind of to talk them through it as you're doing this. You might say, take a deep breath in, let it out, again. So you're listening side to side. Generally, you can go from left to right and listen. And of course, you remember the heart is here, so you're not going to hear a whole lot of breath sounds here, but you will hear breath sounds anterior, lower down on the right. So I usually start fairly high at the apex of the lungs. So Michael, you take a deep breath in and let it out. And in, out, again, and out, again, and out. And then I'm going to listen one more time. Excellent. So I can hear the anterior breath sounds. While I'm kind of in front of him, I'm going to listen to your left side. Take a deep breath in and out. Again, in and out. Excellent. We're going to do the same on the right side. In and out. One more time. Okay, we'll give him a little bit of break. Usually when you are listening to somebody's lungs, you're having them relatively hyperventilate. If somebody is like not very healthy, it may make them a little lightheaded. So always give them a break after you've had them do that. Now we're going to do kind of the same thing, and I'm going to listen to your back. I'm going to listen in at least 3 or 4 areas, going again left to right and listening to your lungs in the back. So if you could take a deep breath in and let it out. Again. Again. Good. Again. Great. Again. Okay. One more. And last one on this side. Good. Deep breath. And deep breath in. Very good. So I've listened in about 4 places. You're not going to hear good breath sounds over the scapula, so you want to stay between the spine and the scapula. Down at the lower ribs, you can listen a little further out. But as you do this, you're going to kind of identify during normal breathing pattern about where the lungs end. One of the maneuvers we're going to talk about is diaphragmatic excursion. So I know that his lungs, normal breathing, end about here. If he takes a big deep breath, he can fill them further down. But as we're trying to figure out whether or not there is fluid with using percussion, I'm not going to start percussing way up here because we know there's air here. What we're looking for eventually is the area of dullness, and that would be lower down in the dependent area of the ribs. So there's a few other special techniques after you do inspection and auscultation, and one of them is what is called vocal fremitus or tactile fremitus, and this is a technique again to see where the areas of lungs are aerated and where there may be fluid. And you can either use the palmar surface of your hands like this, or you can use the ulnar surface like this. And what you're going to do is have him repeat some words. Mostly people use 99, 99, 99, because that makes a very makes a resonant sound. And as he's saying those words, I'm going to move my hands down like this, or down like this, depending on how sensitive, what's the most sensitive area. I tend to use the ulnar side of my hands. And it should be, the vibration should be symmetric. And if it's not, you might find that there's fluid or consolidation in that part of the lung. So Mike, if you'll say 99.
99, 99, 99, 99.
So here, it's about where I no longer feel the little vibrations from him talking. Some people find that some people will use something other than 99, but that's typically what you do. So I felt vibrations to about here, and they were very symmetric. Again, you can use your palms if that works better for you. And then the other thing you can do along those lines, looking as a special pulmonary test, is something that's called egophony, which is, I remember from medical school, it's Greek for goat's bleat. And so what you're going to do is your patient is going to say E, E, E repeated. If there is fluid, that E, you're going to hear it through your stethoscope as more of an A, and that's kind of the E to A is the goat's bleat, and it might tell you that there is fluid or consolidation. So again, so just say E, repeat E a few times for me.
E, E, E.
Can you do it a little slower? E,
E,
E, E,
E, E, E, E.
Thank you. And if you hear it as E, that's normal. If it changes to more of an A sound, then that is an abnormal, and that's called egophony, and that might be done on your patient. The other thing that you may be required to do of finding out if there is pleural effusion or something, or where you suspect that there is reduced aeration of the lung is percussion. And we talked about earlier that, and percussion is a technique where, in general, and I'm left-handed, your non-dominant hand is on the body part that you're going to percuss, and use your dominant hand, either one or two fingers, to see what you're going to do is listen for the sound that percussion makes. Lungs are filled with air, so it's resonant, where you get to either the abdominal, posterior abdominal contents, it's going to sound dull. So what you can determine is the diaphragmatic excursion. So where it goes from resonant to dull. I'm going to first do it with him just breathing normally, and then I'm going to have him take a deep breath and see how far down the lung, the resonant portion of the lungs goes. That gives me a kind of a proxy for how far the diaphragm goes down. If it doesn't move at all there and it's dull, maybe fluid in there. And so what you do, and typically you do one side and then you can do the other. We know that there's air by listening all the way down here, but I'm going to percuss till it goes from kind of resonant to dull. And so about here. So Mike, can you take a big deep breath for me? So you can breathe out or exhale. So the transition was about here, and then what you would do is you can actually measure that in centimeters, and that's about 4 or 5 centimeters. And that's how you would either measure diaphragmatic excursion in somebody who's normal, or you might figure out how much fluid is there. That's using your percussion, and again over the lungs, it's quite resonant, and over the back of the abdomen is dull or less resonant, and that's how you can do diaphragmatic excursion. You can actually do it anterior as well, but it's rarely done. This might help you if you were in a situation where you were going to have to put in a chest tube or take some fluid off. In general, it's these days confirmed with bedside ultrasound before you would do that, but it's a good technique to assess your patient. So again, we're going to talk a little bit about the pulmonary exam on a woman. Again, you want as good an exam as you get on a man. If they are wearing a gown, one of the things to remember is never listen through the gown for the pulmonary sounds. You would get a very, you might hear them, but your ability to diagnose anything is really reduced, and it's improper technique. So again, with the patient's help, you need to listen to at least two areas in the front for the pulmonary exam. You listen with the diaphragm, and this is fairly high up. We can, once it's in place, can you take a deep breath for me? Great, and let it out. Excellent. And then I'm going to just move the stethoscope again. Excellent. And then I'm going to ask you to, if you'll move your right breast so I can listen a little bit anterior. Yep, and here we'll use this. Perfect. So I get a little bit, take a deep breath and let it out. Excellent. So you can relax. Because on the left side you have the heart tissue, of course, and on the right side you can hear more anteriorly. In some situations with listening to the lungs, you may listen laterally as well. For the basic pulmonary exam, you listen 2 places in the front and at least 4 places in the back, and you will go from side to side so you have a comparator. And of course the scapula are here. You're not going to hear any breath sounds there. And then we're going to start at the top and work our way down, listening to at least 3, if not 4 different areas. I'm going to place my stethoscope on your chest, and so if you'll take a deep breath in and let it out. Again, let it out. I'm going to move your bra a little bit. Again, let it out. Again, excellent. And then I'm going to slip my stethoscope right here. One more, in and out. Excellent. And you can untie the gown. We managed to, I managed to get a good exam with it on. If you untie somebody's gown, at the end, offer to tie it again, particularly if they're not going to get dressed right away because it can be uncomfortable. And then just make sure your patient is nicely covered up. And that's how you would. So that is the basic pulmonary exam. We did inspection of the chest, anterior as well as posterior, looking for how they're breathing, use of accessory muscles, any scars, rashes, or unevenness of the breathing. We auscultated the lungs, anterior, laterally, and posterior. And then we talked about some special techniques in terms of tactile fremitus. We did egophony, and we demonstrated the diaphragmatic excursion. So that, along with a respiratory rate and a measurement of patient's oxygenation, would give you the basics of a pulmonary exam.